Good afternoon, colleagues. Welcome to our eco session. Thank you for joining us once again. We are so excited to see all of you joining, and we are hoping that other colleagues will be joining us as the session continues. So today we are going to do our introductions straight in the chat box. Due to time, we are not going to unmute and introduce ourselves, but we are going to introduce ourselves and who we are joining with and where we are joining from through the chat box. So for our last session, we were looking at neuropathic pain management in palliative care, and Mr. Mahlangu was taking us through the topic. My name is Mercy Shabangu. I am with the Eswatini Hospice at Home Hub team. For today's session, we are going to be looking at phantom and psychogenic pain management in palliative care, and Dr. Eddie from Hospice Africa will be taking us through that topic. Can we be reminded, colleagues, that we should keep our gadgets, our phones, muted or in silence so that there's no disturbances or any background noises. And that if we want to ask any question or if we want to make any comments, we can use the chat box unless the presenter asks us to or requires us to unmute and actually share with the entire team. So I am not sure if Dr. Eddie is ready to start with the presentation.
Yes, good afternoon, ladies and gentlemen. Are you hearing me? Do I have sound output?
Yes, we can hear you, Doc.
Okay, wonderful, wonderful.
Afternoon.
Just quickly confirm that my slides are showing.
Yes, they are showing clearly, Doc. Thank you.
Wonderful. So, ladies and gentlemen, I would like to say thank you to the Hospice at Home program for inviting me to deliver this session and share with you about phantom and psychogenic pain management in palliative care. I'm Dr. Eddie Mwebesa. I'm the Clinical and International Programs Director at Hospice Africa, Uganda. I'm a palliative care physician, and I love to teach. I'm from East Africa, so my accent will be East African. I hope it will be understood by our brothers and sisters from down south. What I will be talking about is just having a short recap of what palliative care is. I'll introduce the concept of total pain, and then I'll delve into phantom and then psychogenic pain management and assessment. And then hopefully there will be some spare time for questions and answers and some discussions and sharing of experiences from the participants. This consensus definition by the International Association for Hospice and Palliative Care is a more recent one, and I think it is an amazing definition for palliative care. The active holistic care of individuals who are suffering because of severe illness, and the goal of their care is to improve quality of life of patients, their family, and their caregivers. So just to emphasize as we go into this session that we shall be focusing quite a bit on quality of life, and we'll be covering what is preventable if possible, but also specifically the assessment and management of pain, phantom pain and psychogenic pain. You may have already come across the concept of total pain, and it was well described by Dame Cicely Saunders, who was the founder of the modern hospice movement. And what she emphasized was that whereas many patients come to us initially because of physical pain, and their entry point is usually, I have pain, this is hurting, this is distressing. Usually the physical pain will not be in isolation, and it will be within the context of psychological pain, social pain, spiritual and existential pain, and that there is an interaction and an interplay which is complex among all these fears. And that is something that we see all the time in palliative care. What we see is that initially patients may come with a physical complaint and symptoms, but as we clock them, as we review them, as we get to know more and more about them, the psychological, social, spiritual, financial, practical aspects of their being come into play. And these are very, very important when we're approaching phantom pain and psychogenic pain, because in both of these types of pain, the social and especially the psychological components are very pronounced. You will remember also Dr. Elizabeth Kubler-Ross, who did a lot of research among patients who are dying. And what she asserted was that the non-verbal aspects of our work are very, very important. And it is useful to touch patients, to show them care, to listen to them. And we're talking about active listening, hold their hands and walk with them that journey, that difficult journey, especially as they reach end of life. So as we talk about these two types of pain, please just keep these essential aspects in mind. When we talk about palliative care, we really need to talk about it in the context of wellness, illness, and end of life. Most patients that we see in palliative care will have very severe illness, cancer, HIV with AIDS, serious organ diseases and organ failure, and illnesses which are quite severe. What we usually will have happened is that this patient is coming from the context of a family, and they're initially well, but then they go through being diagnosed with a serious illness, and that translates that person into what we call a patient. A patient is a person who has an illness. They are still usually within a family, and over the course of time, many of them actually do deteriorate. Their health fails, and many of them actually reach end of life, and they have to go through a very difficult door, which is the end of life door, death. When that happens, that phase can be quite challenging for patients and the family, and often after the patient has died, the family is left with a sense of emptiness. They are grieving, they're in bereavement. So when we talk about assessment and management of phantom and psychogenic pain, we really need to understand that for most patients in palliative care, the lifespan might be shortened, and there might be a lot going on in their lives because of the severity of the illness that they are suffering. So let's talk about the phantom phenomenon. The phantom phenomenon was first described in 1552 by a French military surgeon. And what he described was people who experienced pain or experienced sensations, or the illusion that part of their limb was still present, yet they had had an amputation. They had had surgical removal of either part or the entire limb. So this description really is something called a phantom phenomenon. And literature describes, three different things within the phantom phenomenon. There is a phantom limb pain, phantom limb sensation, and stump pain. Stump pain is the pain that patients receive within the area that has been surgically manipulated, where they have cut. There may be nerves, and usually there is a wound that needs to heal. And the pain right there at the surgical site is called stump pain. However, phantom limb pain is pain that is imputed, that is referred to a limb that has been amputated. So someone is complaining about pain in toes, but they have had, for example, an amputation at knee level. Now, when they describe that kind of pain, it's called phantom pain of the toes, because it's pain in the toes, but they've had amputation at the level of the ankle. At the level of the ankle of the knee. Phantom limb sensations are sensations other than pain that are referred to the amputated part. So these can be feelings of, insects crawling on the skin, or fire, or tingling, shocks. These are the kinds of sensations, but they are not pain. The phantom phenomenon is quite common, and the incidence is as low as 2%, but as high as 97%, depending on the study design, the population studies, and how they defined the phantom limb pain or the phantom phenomenon in the study. What we know is that it's very, very common. And this is regardless of whether patients have been amputated because of cancer, or because of a landmine, or because of gangrene, diabetes, or other causes of the amputation. It can be quite disabling. Many patients talk about pain that seems to ascend. So they may talk, maybe they have had an amputation above the knee. So they will talk about pain in the toes. And then when you ask them, they will be talking about pain that is now no longer in the toes, but seems to be in the ankle, in the calf. So it is sort of receding upwards in a phenomenon called telescoping. So telescoping occurs in many patients, and usually it comes ahead of the resolution of the phantom phenomenon in that limb for that patient. So what have we seen also? The literature talks about the phantom phenomenon not just affecting limbs, but you can have it when people have, for example, have lost breasts. So when someone has a mastectomy, they may complain of pain or sensation in a breast that really was amputated, and they are complaining of sensations or pain within that breast. The same can occur to other organs of the body. For many people, it resolves, but there are a number of factors that might lead to its persistence. And many times patients have more than one phenomenon. So they may have, for example, limb pain, phantom limb pain, but also phantom limb sensations. They can have pain together with tingling and stabbing and fire-like sensations within the limb. So many times they have more than one type of the phenomenon happening. We shall talk about the relations and what usually happens. But before we do that, the mechanism for phantom pain needs to be understood. It is quite complex. as you can imagine, someone will be complaining about pain in a limb that is not there, that has been amputated. It's absent, but they're complaining of pain. So definitely, what we know is that the mechanisms are very complex, and the basis around all this is the fact that the brain controls a lot of the sensation that we experience on the body. There is something called homunculus, and this is really a mapping of the body around the cerebral cortex. And you will notice that there are certain parts of the body that have a very large distribution of the body map on a large portion of the brain. So the hand has a very large representation together with the arms. Similarly, the legs have a very, very big proportion. But the face, the tongue, the lips also have very large representation on the brain. So you can see from this visual presentation of how the body is mapped out on the brain that when someone has an amputation of the leg, for example, a significant part of the brain that has been registering the impulses and the electrical sensations from the leg will still be present and active. And also because the surgery has transected nerves, the rest of the nerve is active even when the main body part, which is the limb, has been removed. We also know that there are certain parts of the body that have very early and very strong representation on the brain. And the whole idea here is that the brain seems to retain a certain memory of the pain pathway and the sensation pathway from distant parts of the body, whether they are the fingers, the hands, the toes, the ankles, the limbs, the hands and legs. And that memory is retained, especially in adults, and especially when parts of the body that had a very strong representation, for example, the hand, are amputated. The processes are quite complex, but this diagram really lets you see that limb amputations are actually very, very much prone to producing the phenomenon of phantom limbs. So what have we seen in the literature? When you see, they will be talking about the phantom phenomenon sometimes happening very early after surgery for many patients. The pain may be constant or it may come and go. What we have seen is patients who have severe pain in the preoperative period have a high chance that they will have phantom phenomenon even after amputation. Also, those who have postoperative complications, whether it is neuromas, infection, bleeding, anything that complicates the post-surgery phase, will likely bring up maybe a preoccupation of the patient with their condition and a high chance of the development of the phantom phenomenon. Also, proximal level amputation. So someone who is amputated above, say, the knee is more likely to have phantom phenomenon than someone who has just an amputation of one toe or an amputation at the ankle level. The higher up the amputation, the higher the chance that the phantom phenomenon will occur. Patients who have general anesthesia as opposed to regional anesthesia have also been shown to be more prone to the phantom phenomenon. But by and large, there are all kinds of things that may trigger or that may worsen the phantom phenomenon. So some people describe, for example, that early morning when it's very cold, their pain is worse than when it is warm. Others, when there is rubbing of clothes against the stump, they feel as if that pain is on the toes of the limb that was amputated. Some people, it is walking or exercise that will either aggravate or relieve the phantom phenomenon. Scratching, distraction. What we see also is many patients who have mental stress, if they are anxious or have depression or have any reason to have a mental state that is disturbed, those kinds of patients are likely to have worsening of the sensation that they have phantom pain. Patients who have intestinal or backache and those kinds of challenges might have worse phantom pain. And again, this is likely that they either have already comorbid illnesses, they have concurrent illnesses, or these back intestine headaches and other body pains are part of a generalized pain experience that these patients have. Patients who have had stump problems, infections within the stump, complications, bleeding, those patients usually will have challenges as well with the phantom phenomenon. What has also been seen is that the early use of prosthesis will decrease the development of the phantom phenomenon. So if after, say, surgery, a patient is mobilized early, they are gotten out of bed, they are made active, and at the earliest opportunity, they are given a well-fitting prosthesis, they are less likely to have or to be fixed tested on the phantom pain. And this may be two ways. One is they're getting on with their life and they're trying the best they can to be active and to get well. But on the other hand, also it is possible that the prosthesis will change around how their body understands their orientation in space and how the prosthesis will modify how the nerves in the stump operate so that they rewire to have a sense that there is a limb when there is a prosthesis or that there is acceptance of the disability by the patient. Why do we need to talk about the phantom phenomenon? The phantom phenomenon has been associated with depression. Patients who have unresolved phantom pain sleep poorly, eat poorly. They tend to have lower function. They have a sense of disability. Some of them feel sorry for themselves. They generally suffer poor quality of life, and they may be prone to medication overuse. And some of them actually do abuse opioids. So we really need to handle the phantom phenomenon. Whenever a patient is amputated, even if it's because of cancer, and their prognosis is poor, their anticipated lifespan is meant, it could potentially be short, we still need to pay attention to the fact that the phantom phenomenon may actually arise. So how do we manage? The phantom phenomenon is a challenge. It's a real challenge, both to the interdisciplinary team and to all people who are involved, right from the surgeon to the physiotherapists to the psychologists, psychotherapists. It is not easy. When you look at the literature, there are a number of interventions. Some of them are pharmacological, some of them are psychological. And often what is happening is that they use a combination of therapies within the context of a multidisciplinary team discussing whatever is arising, to try to mitigate the effects of phantom pain, but also to try to control the pain itself. When I was reading, I found this very interesting statement. None of these therapies is fully effective and reproducible in a large number of patients. So unlike illnesses like HIV, where you can say highly active antiretroviral therapy is going to be very, very effective in controlling AIDS, in the management of phantom pain and the phantom phenomenon, what works for one patient may not necessarily work for another patient, and treatment really has to be individualized. There are maybe a 2 or 3-pronged approach. The first one is, because we are aware of the phantom phenomenon, we need to, as much as possible, prevent it from happening. And we are fortunate that literature has come up very, very well to support the place for primary prevention. So pre-surgery anesthesia should be done, especially if it can be regional as opposed to other forms of anesthesia. So rather than giving a systemic painkiller, if you are able to do regional blocks, that is very, very good. It will help to reduce the chance that phantom phenomenon occurs. Patients should be prepared psychologically, they should be counseled, and they should be allowed to express themselves and their concerns addressed. During amputation, it is best that the best possible amputation technique is used. If patients can withstand regional as opposed to general anesthesia, that would be the best. And amputation should be done as low as possible, rather than as proximal as possible. It means if the gangrene, for example, or the cancer is cancer of the bone, and it is affecting the foot bones, have your amputation as close as is safe to the part that needs to be amputated, as opposed to more proximal, higher up, nearer the body. And then provide a prosthetic device and mobilize the patient as early as possible. The other thing that we need to talk about is the post-op period. After surgery, patients should receive a combination of therapies, and we shall be talking about them one after the other. So there are 2 parts. One, before primary prevention. Second is after the surgery. What do you do? The management is a mixture of things. This first slide has pharmacotherapy, which is treatment using medicines. Anticonvulsants like gabapentin, carbamazepine, phenytoin are very good for controlling shooting kinds of pains. Tricyclic antidepressants and other kinds of antidepressants are very useful for burning pain or the sensations that insects are crawling. Intravenous lidocaine has been shown to be very good and useful for patients and especially if the doctors and nurses are able to administer it, very slow infusions. The analgesic ladder is useful. Interestingly, phantom pain, just like neuropathic pain, sometimes will respond to opioids. And methadone is a particularly good one, not very widely available, for example, even here in Uganda. But morphine, good old morphine, oral liquid morphine, or tablets of immediate release morphine, are important both in actual treatment of moderate to severe pain post-op, but also have been shown to be useful in the treatment of the phantom pain when it is reported. Calcitonin is in the literature is the only drug whose efficacy has been well proved. And it is quite comparatively safe medicine to use for adults, 200 micrograms per day. So if you have this medicine for a patient with problematic phantom pain, try it. Electrical stimulation, massages, gentle touches, and other physical therapies are actually also very useful. Surgically, sympathetic blocks and other nerve blocks are very useful. The challenge with some of these methods is sometimes after surgery, neuromas form. Neuromas are small swellings that occur at the ends of nerves, or sometimes occurring at the nerve junctions and at the synapses. Neuromas are problematic because they propagate pain, and it may be referred to as phantom pain even when the limb has been amputated. So for patients where the neuromas are problematic, thermal lesion in the stump has been shown to provide better outcomes. Some of these interventions are quite advanced, and they may not always be available in